Hi, I'm Jack West, medical oncologist at Swedish Cancer Institute in Seattle, Washington, and also the founder and CEO of GRACE, the global resource for advancing cancer education. I'm here today with two great colleagues and faculty members of GRACE, Dr. Nate Pennell, assistant professor and lung cancer expert at the Cleveland Clinic Foundation in Cleveland, Ohio, and Dr. Mary Pinder, assistant professor at Moffitt Cancer Center in Tampa, Florida. Thanks for joining us. We're here today for a program called Direct from ASCO, Highlights and New Approaches. This is actually the last day of our big ASCO annual meeting, the biggest cancer conference of the year around the world. We'll be talking about some of what we've seen, just initial glimpses, not with a lot of detail about this, but at least some of our first impressions and thoughts about the implications for patients, caregivers, and docs all over. So thanks for joining us. Let me also say this program is a partnership between GRACE and Longevity Foundation, and we thank them for their support in making all of this possible. So let's talk about some of the high impact or potentially high impact presentations of the meeting, starting with one that was the first of an oral session on metastatic lung cancer called Biomarkers France. Nate, can you tell us a bit about what that study showed and the potential implications of it?
Sure. So this was, I think, a very exciting study that the idea was, we understand that lung cancer isn't a single disease. In fact, it's probably a lot of different diseases that can be differentiated by particular molecular tests. And all of these to date have been done generally at single institutions or at small groups of institutions where a number of patients will come in and be tested, and they've demonstrated that they can identify these different types of lung cancer by testing. What's important about the Biomarkers France study is that they did this on a countrywide scale. So they were able to take 10,000 lung cancer patients from all over France and have them tested centrally for a variety of molecular subtypes of lung cancer. So, of course, the two most important ones would be EGFR mutation and ALK, but they also, interestingly, were able to incorporate some more, I would say, up-and-coming markers like HER2, BRAF, PI3 kinase, and KRAS, and they were able to test the vast majority of the 10,000 patients. The results were very similar to what was seen in the single institution and previously published studies. About 27% were KRAS, about 10% had EGFR mutations, about 4% had ALK, and then the rest of them were less common. But I think the most important thing was that they were able to do this, and they were able to organize this on a countrywide level, which is great when we think about applying this to patients worldwide. We now know that it's possible to do that. They also showed some data showing that about 60% or so of the patients had their treatment guided by the testing, although if you actually look at the results from that, most of the patients got chemotherapy. So the testing basically told them that, chemotherapy was probably the best choice for them, and that's fine. At least the ones for which they had effective treatments, like the EGFR inhibitors, were able to get that.
So the key point was that you could actually roll out molecular testing on a grand scale and really apply it, not just at a few centers.
Yeah, absolutely.
Because you made the point in a poster discussion commentary a couple of days ago that we had a limitation in that even if we have great techniques for detecting molecular markers by tumor tissue or serum, as long as people need to get on a plane to participate in clinical trials, that's a real limitation. We need to make sure that everything that looks promising and as potentially practice-changing in a limited center needs to be able to be applied, far and wide, I would say.
Yeah, this is interesting. This is something that Europe does very well. I think it has a lot to do with the way the healthcare systems are set up there, but absolutely. Practically speaking, we have to be able to look for all of these molecular tests essentially everywhere where the patients are. And then the most important next step, and that was probably one of the things I was perhaps a little disappointed about this study, was that only about 2% of the patients, of the 10,000 patients, went on a clinical trial. And that's something that clearly has to change. But that wasn't the main goal of the study. The study was successful in showing that they could do the test. Now the next step is apply the testing to directing the patients to trial so they can take advantage of the information we're getting.